must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hey everybody, thanks for listening to another episode of the HET Podcast. My name is Brandon Powen, and I'm one of your hosts. And for this episode, fellow co-host Stephanie Wyrock and I sat down and chatted with Dr. Brendan Sullivan. And what we really talked about was so many things regarding advocacy, but especially along with Brendan's unique involvement initiative with really working to successfully advocate for change to the workers' compensation fee schedule in the state of New York, along with other avenues related to that issue. So we really dived into a lot of those topics. Now, I'm going to introduce Brendan here, and then I'll have him kind of share his story as well. But for those of you who aren't aware, Brendan Sullivan began practicing PT in 1997 after graduating from Utica College of Syracuse University. He is an ABPTS board-certified orthopedic clinical specialist and a certified strength and conditioning specialist through the NSCA. He is a member of the APTA and is active in both the Workers' Compensation Research Institute, New York Advisory Committee, and the New York Physical Therapy Association Public Policy Committee. Brendan is also currently an orthopedic manual physical therapist fellow in training with Bellin College, and he opened a small personal training and wellness center in 2011. And only after 2 short years, the business expanded into a more expansive gym where clients and local residents could utilize the facility during the week. Well, Brendan, thanks so much for coming on. Thanks for all of your time and efforts that you've done throughout this initiative to really drive positive change, because I think that really just shows what a role model you and your team have been to really make this process better for us. But, to dive into that, I know with our topic today being more involved with, specifically with advocacy, with payers, and kind of getting your side of the story and how you've achieved that. Would you mind just kind of sharing your story with how you initially got involved in advocacy and why you got involved in this avenue of it, and even how you opened up your own wellness center?
Yeah, absolutely. No, thank you so much for having me on to discuss advocacy, and thank you guys both and to your whole team there for what you do, putting the podcast out and really good content and information for the profession and for other professionals in healthcare. So just to be clear up front, while I do serve for 2 different committees on NYPTA for the New York chapter, anything that I'm sharing is, kind of personal opinion, personal account, unless, I'm giving some, direct recount for that. So I'm not speaking on their behalf. So, to your question, everybody has a journey and a personal story. For me, my interest in advocacy started all the way back when I was in PT school. I went to Utica College here in New York, and we were a new program at the time. And, getting approval through the CAPTA for candidacy and accreditation was something that, we got to see really upfront and personal. I was always, involved as a student as a part of the annual lobby day. So I got to see some of that. So, kind of my perspective was brought into that world, very early on, being a student. So after I graduated, I practiced in New York at a local medical center, but then I moved down to Myrtle Beach, South Carolina, and that was a different practice environment from a couple of standpoints. And I was going from hospital-based to opening up a clinic for a larger, therapy and rehab company. And that, in South Carolina, I had immediate direct access to patients, and that's not something that New York had at the time. And this was, in the late 90s, so the Balanced Budget Act had came out, and there was really a rippling effect when that Budget Act had passed in the profession. I made the decision to come back to New York and open my own practice, and that's kind of what led me into taking the next step with advocacy, and that is the idea that we didn't have direct access in New York, and what was it going to take to make that a reality. So I got back involved a little bit with what's called our Eastern District here in New York. There are several different districts for the state association, and I was really lucky enough here in the Eastern District to be mentored, and I consider her a friend, Doreen Frank. She's another private practitioner, and she's really legendary in terms of what she's been able to accomplish over the course of her career. She was able to help us navigate, and as of 2006, get direct access passed in New York. And she's recounted the story to me, on a personal basis. But there's just a lot of those personal relationship building issues and components to getting a bill passed, and that's some of what helped get that over the threshold and make that a reality in New York. So really from, about 2001 to 2016, I, would consider myself, a kind of a traditional, private practitioner advocating in the community for brand awareness for my practice, whether that's to, raise public awareness just about my clinic or about issues that I think are relevant. And I think on that point, advocacy can mean a lot of different things in the profession. The type that I'm most interested in is definitely the public policy realm, where that's a primary concern centered around anything from the Medicare cap, the licensure compact, State Practice Act, direct access. More so for myself on a state than a federal level is where I've been involved. And more recently, I think what I've taken note of is that advocacy can mean other things for other individuals. It might be professional advocacy, personal brand awareness, that sort of thing. And while, those forms of advocacy are great, whether that's, just for your own practice or individual, I think where we can make the biggest change is kind of outside the echo chamber and meeting and getting involved with other stakeholders. Having observed and seen some of the work, Stephanie, that you've done in really advocating for therapists to be able to distribute disability, parking placards and what that took, and testifying. That's definitely more my brand of advocacy and kind of where I see myself fitting in there.
Yeah, and advocacy is definitely not an easy process. Like you said, Brendan, it takes time, it takes resources, and it takes building up very strong relationships with stakeholders in order to be successful. So before we kind of dive into the specifics on that, tell us a little bit about how workers' comp policy is made or decisions are made regarding physical therapist reimbursement. And then talk a little bit about the stakeholders that are involved in determining the fee schedule that basically lets us get paid for our services.
So yeah, absolutely. I mean, we'll take a short trip down memory lane. I mean, to be perfectly honest, even as of, recent history over the last 4 or 5 years, I had no idea, how workers' comp decisions were made regarding policy for reimbursement or medical treatment guidelines or otherwise. And for myself, I had been in practice for about 9 years, as of 2010, and I was attending a state chapter annual conference in Saratoga, New York, just north of where I am here in Albany. And one of the speakers was Jeff Hathaway. And again, I consider Jeff to be a titan in the PT industry. He's a therapist that at the time was involved with the state association. He was, I believe, chairing the payment advisory panel. And at this meeting, again, it's a little side session that was going on, at the chapter event. He spoke to the group, primarily private practitioners, about his dealings with the state workers' compensation board. And essentially, he talked about, some of the discussions that went on regarding regarding the workers' comp fee schedule, and in particular, how that can impact rates that commercial payers pay. And typically what he described is that, a commercial insurer will look at, what is the benchmark in a given area? And they'll either look at workers' comp or Medicare and, decide their fees based on whichever is lower. They typically wouldn't pick the higher one. And what he went on to explain to the group is that here in New York, there's something called a RVU cap on our services. And that is to say that follow-up visits have an 8 RVU cap, and RVU being relative value unit. And that's one of the fundamental components that goes into calculating how fees are calculated and they come to an ultimate value and they're paid. And 8 RVU for a follow-up visit basically means that less than a half an hour of service is going to be paid for. So while it's a cost-saving mechanism, to the workers' comp system, it also is kind of an incentive to do volume, because if it means only 25 minutes are being paid and I've got a 45-minute session with someone, then there's an expense on the practice side, on the provider side, that isn't going to be met. So, the quality of services, the ability for therapists to provide that good one-to-one care was diminished. And, some of that information, as he had wound up describing, in his conversations, both with the group and I believe with the workers' comp board at the time, was that there's going to be more therapy visits that are required to get somebody back to work if therapy visits are more watered down over a period of time, because we can't provide the kind of one-to-one service. So again, this information was new to me at the time. Despite having practiced several years, I didn't understand, the intricacy of, the methodology that was used to arrive at PT reimbursement. I mean, typically within each state, medical fee schedules are, done on a state-by-state basis. And about 30 out of the 50 states use the RVS, and that's the resource-based relative value scale, to determine reimbursement. And they do so if 30 out of the 50 pretty much take Medicare and they add a surcharge. So that's an additional fee above and beyond what Medicare would pay. And a lot of that regulation is codified into workers' compensation law. So just as an example, if Medicare pays $1 for something, workers' comp might pay a surcharge of 20 cents, so $1.20. So in Pennsylvania, I believe it's 120% of what Medicare pays. In Texas, last time I looked at their regulations, it was 160% of Medicare. And what the RVU cap based on our calculations were is that for a follow-up visit that a therapist might typically provide, here in New York up until recently, it might have been 50 to 60% lower than Medicare. So it was well below, the kind of established standard. And what New York used instead was more of its own proprietary formula. So it did not base things on Medicare or otherwise. And again, our fee schedule had not been changed since 1996. The stakeholders that are typically involved in changing fee schedules are anything from medical providers, business groups, labor unions, obviously the insurances. Some states don't have a fee schedule, New Jersey being one of them. They use what would be called usual and customary rates. And typically, your state legislature is going to pass, laws surrounding this. And that's why it might be slow to change. So my personal involvement and knowledge regarding the fee schedule and all of this, obviously it started with Jeff's presentation, but it did not take shape until around 2015. At that point I'd been in private practice 15 years and there'd been no change. And I'm obviously running my practice and wondering, when is something like that going to happen? And there was an attempt by our workers' comp board to put out a proposal that said, hey, we want to follow Medicare, add 20%. They did so because they wanted to enhance the number of providers that were participating in the program. But unfortunately, what had happened there is that because they were going to balance how this was going to be paid for with cutting reimbursement to certain providers and increasing it to others, well, you can imagine other medical professionals were not going to go along with that. And they kind of rallied to have that shot down really at the time.
Well, it's Brendan, it's really interesting just kind of gathering all that really goes involved kind of behind the scenes to really come at those ultimate numbers that kind of drive a lot about what we do and what we are able to accomplish financially as a profession. But, and I know you kind of mentioned some of this earlier, with kind of within, workers' comp and the medical fee schedule, but how is what you were kind of saying about how reimbursement is determined, how is this in comparison to maybe some of the other big players that we see it from an insurance standpoint, like, Blue Cross Blue Shield, Cigna, and even maybe expanding on Medicare and Medicaid?
Yeah, absolutely. So, I mean, here in New York anyways, it's, for my personal knowledge, commercial insurers, it's relatively elusive with regards to how, they come up with a set formula for reimbursement. Again, I think unofficial guideline is, where is Medicare and where is workers' compensation? And that is simply a benchmark. To my knowledge, insurers, don't have any kind of mandate or otherwise to follow those exclusively. And it's just, again, a metric that they might look at, use and determine and rely on. And I think that the example of that is, is something like let's use Blue Cross Blue Shield that, or even United Healthcare that, they follow, what Medicare says about, intervention like iontophoresis. And it's easier for a commercial insurer to say, look, this is what the government does or doesn't pay for. So it's an easier case to make that if something is denied, that what they're doing is actually consistent with governmental policy, and it's easier for them to defend. I think the concern for a commercial insurer might be that if they were all keeping their rates, artificially, relatively at a low level, there could be, a case to be made that there's some degree of collusion that, takes place. So they're going to, again, want to look at what are the external sources of information and try and go off of that. I mean, for my own practice, it's, from the time that I started, pretty much, rates aren't negotiated. It's more or less take it or leave it. You can join our network and this is, really what's available. In our area, most plans are, have a bundled fee where things are not paid similar to Medicare, where it's, fee for service, line by line, CPT code, one at a time. United Healthcare still does so. So each has their own ability to come up with what formula they believe is going to work best for them. I mean, here in New York, there are, a few components that go into what might be available for an insurer to pay. And one of those factors is that there is a mandate in New York that commercial insurers use, I think the number is 90% of their revenues on patient care. So, 10% can only be administrative related expense. And obviously what can factor into that is anything from state government coverage mandates, the high cost of prescription drugs. And obviously there's only going to be so much money to be reimbursed to more individual practices if you have large scale hospitals that have a large network that are able to negotiate higher fees for themselves. So all these kind of external factors will go into, how things compare to, between workers' comp or Medicare and a commercial payer. But again, to my knowledge and understanding, there's no mandate in particular or set formula that they use.
I remember when I moved to Connecticut a year ago and sat down with our HR person at the company that I work for now, and we chatted about insurance and how much each insurance company pays and like what do they pay for, what do they not pay for. And I remember thinking to myself, man, I'm so glad that I have been in practice for 3 years and have had experience with all these different insurance companies, because if I were a new grad listening to our HR director talk about all these different models that these insurance companies have as far as payment goes, I would have been so lost. In Minnesota, we had 3 payers, and in Connecticut, we have way more than that. So I'm interested in just asking a little bit of a follow-up here. And, how do new grads learn about this stuff, Brendan? It's a lot of complexities. It's a lot of, when you're sitting here talking about insurance companies, sometimes people's eyes will glaze over. What are some tips you have for some newer physical therapists on how they can understand these fee schedules and kind of figure out the complexities of insurance.
Yeah, so you're talking about the bane of my existence as a private practice owner, someone that hires, existing therapists and new graduates and otherwise. And, it is extremely complex. The way that things for myself evolved over the last 18 years of owning my own place is that obviously, we didn't have electronic health records, when I got started. We were doing everything on paper and therapists would fill out a charge sheet. And that charge sheet would go out to the biller that we used externally. And what I would do is actually sit and review any of the paper, forms that came through. And I would look to see, one of my therapists billed iontophoresis, and that's going to go to United Healthcare. And, we should have let the patient know that's not going to be covered, or, all these rules that you wind up learning just through the experience of being an owner. And where that changed for myself, because I really was investing a lot of time in trying to remind therapists about these rules, is that for myself, it just came down to a software solution. And, we, at my office for close to 10 years now, we've been using the WebPT program and have really customized our own version of it. We've used some custom integrations to actually make it so when a therapist is in a note, that if they go to bill for a CPT code that isn't consistent with workers' comp medical treatment guidelines or individual insurer, that pretty much within the note lets them know. I think for any person that's just getting started, a new graduate, or you're switching from maybe hospital base or long-term care into private practice outpatient, it's very, very difficult to remember all of the rules. And I pretty much had arrived at that point that, my therapist didn't have time for me, to keep tapping them on the shoulder, reminding them about this or that. And I think electronic health records, give us the opportunity to kind of build some of that customization into it, where it's available, where you can either do it yourself or work with individual vendor. I think I had a side conversation with Rick Gowenda from Gowenda Seminars about this. And what he described to me is that nationally, I think that there's around 10,000 insurers. And, it would be very hard to build a centralized database for that sort of thing. But when you're, a clinic like mine that is in an individual region, you can create more of a customized situation that covers, I would say, probably 95% of the difficulties that come up. I mean, to a certain extent, I think, other practices might not have that kind of implementation going on. And, they would have to go through and learn about it one bit at a time. But it's extremely challenging, just what you were describing, going to a different area where there are a lot of different plans and a lot of different rules that go into that. I think WebPT does a really nice job with Medicare compliance, but they can't possibly on their own keep up on all the individual commercial payers and how things might even vary within just one commercial payer to the next.
Yeah, I think that's really good advice. I know that I was definitely thankful for the experience that I had in advocacy, and I was thankful that I understood all this stuff. So it's a lot easier, I think, for me to adjust. How would you say the workers' comp fee schedule has changed in the past year in New York and across the United States since you've started all this advocacy stuff?
Yeah, so that's another great question. I'll give you the short answer and then kind of the longer arc about how things came to be, at least through my eyes. So the short answer is that as of April 1st, this year, the fee schedule here in New York changed in the sense that follow-up visits, the underlying methodology for how the visits are paid, follow-up visits are no longer under the 8 RVU cap. They're under a 12 RVU cap. And, what is the other part of the equation that goes into that is something called a conversion factor. And that basically accounts for inflation or the, value that's associated with the service that's being provided. So you multiply one times the other, and then you come up with a reimbursement rate. And across the state, here in New York, we're looking at an 86 to 95% increase in the fees that are paid, for follow-up visits. And there are increases that go into reevaluation and evaluation, but, that should give, perspective of the magnitude of the change. That kind of, an effort took a substantial campaign from the state association, and it was primarily based around addressing the opioid crisis. This is definitely for us what we describe internally as a generational shift in PT reimbursement, and something that'll have a positive impact on a therapist's ability to care for injured workers. I mean, again, if the system was incentivized towards volume and not value, it's hard to for therapists and therapist practices, really to be able to provide that sort of thing. Changing a medical fee schedule on that scale, takes a collaborative effort, and it takes a state chapter. Team members that I worked with included, the previous and current president of the association, Mike Mattia, Peggy Lynham, our executive director, Kelly Garceau, Brian Lucy, Jake McPherson, Marcia Spoto, and an alliance of independent physical therapists, which is a private practice group here in upstate New York. And, the way that I would describe, that increase, the end result, the short answer, for you is that it's a long and extended process to get there. And what I'll take a couple of minutes describing is kind of the backstory of how do you get there? How do you get to, that kind of magnitude of change? And I think, we hear it all the time. I see it in online forums and otherwise where individuals are frustrated with, the national or perhaps their state association that not enough is being done. And I think, there's a case to be made here that this is a success for the association, a success for how teamwork comes together, because no one person can do it alone. And, what I'll detail is kind of through my eyes, how I came into the process there. My version events, I guess I would say, are designed, really to inspire another person who's kind of maybe on the outside, not a member, is a member, but isn't that involved, to how we got there. And it really goes back to 2015. Again, I made mention earlier of how, things were shot down within the state legislature. And I was curious why. I mean, we had all kind of heard at that point across New York that there was going to be a fee increase. And when the time came and went and there was no change in the explanation of benefits that we were receiving, I was curious. I'm like, what happened here? I thought that this was a, kind of a slam dunk. And I made what I like to describe as the grave mistake of actually reading the underlying testimony that went into, the rejection of the fee schedule increase. And in studying that, what you came to realize is that stakeholders, really had their own vested interest in things. They were looking out for their own, interests. And what was clear to me in reviewing things is that physical therapy was referenced as a part of it, but there was actually a group, not a labor union group, but their, represented state employees. One of the groups said that this fee increase would actually hurt or limit the ability for injured workers to access physical therapy. And I just, I remember looking at that line in the testimony and saying to myself, wow, we're not doing enough to speak. We're letting other people speak on our behalf. And that's, the point for myself where I wanted to get involved. So I saw, really within the testimony where the Workers' Comp Research Institute, which is out of Boston, was referenced. A lot of their information, they are a independent not-for-profit. I think they're the largest group that independently studies workers' comp across the country. And they do benchmark studies looking at anything from outcomes to, premiums that are paid, benefits that are paid out, medical fee schedules. And, honestly, all I did was I picked up the phone one morning and I gave a call to their executive vice president, and the person's name is Ramona Tanabe, and she gave me a good 45 minutes on the phone. And I explained to her, really, what had transpired here in New York. And what she had told me is that she'd studied New York for 20 years and she'd never really heard from anybody from New York regarding their findings. And, at the end of kind of the exasperated conversation, she said, Brendan, I've got great news. We, in many other states, actually have a advisory committee, and we're going to form one in New York. And it's typically made up of labor and insurance and physicians and actuarials, and we have a physical therapist in other states. And would you be interested? And I'm like, well, absolutely. This sounds like the kind of room, that I want to be in. So with that experience for myself, I took to, reaching out to the state association, and, when an opportunity came up to serve on the public policy committee, I felt like, workers' compensation was an area that, I could relay pertinent information that was coming from WCRI, so that if the issue came up again, we would kind of have a running head start going into it. It was pretty apparent to me, keeping up on what the Workers' Comp Board was putting out there, that there is a large internal review process for how they do business and how they want injured workers to have their care received. And so it would behoove us to really stay involved and on top of that. And they were looking at anything from, further refinements to the fee schedule to bringing physical therapists and other professionals under workers' comp regulation as participating providers. So, within our, internal discussions, we got to the point of saying, well, maybe we should, have a conversation with the board and actually go and have a sit down meeting and kind of get acquainted. There's some new leadership there. And in February of last year, in 2018, I got the opportunity to give a presentation. I was there with several other members of the state association, but I was, kind of having the background and studying the issue, got an opportunity to, lead the discussion somewhat. And the biggest thing that I would say when you have, that kind of magnitude of a meeting, is that you have to take a very important perspective going in. And I had talked to a lot of other therapists leading up to this point. I mean, we had, a good month lead time going in. And I talked to friends, colleagues, people that were in the association and out. And many, said to me that, Brendan, when you go in there, you need to talk about that fee schedule. Like, you cannot let this opportunity go by and not address that fundamentally. And, I draw the analogy to if a therapist comes to interview at my office, is it a good idea for them to discuss salary and start talking about benefits before we're talking about the position on day one? And I just, that person probably isn't going to get hired at my office. And I didn't think that for myself, it was a really good tack to take. And, the fundamental point of going into a presentation like this is that you're going in there to make a presentation for them or to them. In a scenario where you're giving a presentation to someone, they don't know much about the information that you're providing. Maybe they know the topic, but they don't know it in depth. And you really are going in to educate and win them over. My estimation of having, studied the Workers' Comp Board and looked at their internal workings as to how they were looking to modernize the system is that we already had them to a certain extent on our side, but what they needed from us was, a presentation that would help them take things up to the next level. And that is to say that they needed the information in a fashion that was relevant to them. How is physical therapy going to help us reduce cost and get better outcomes? The argument, it wasn't so much an argument. The presentation, centered around several key points that if whoever was in the discussion could take to the next level in state government and be able to take that information and say, here's why we need to make a change this way. And it would be very easy. So instead of going in with the idea of, hey, we're going to discuss fee schedule and dollar amount, and this is wrong and it should be this way, you're putting yourself in a position where you're there to help, and you're there to provide them good information and provide this underlying substance for why a change should be made. And several discussion points came up. in particular, regarding some of the medical spending, the high amount that was spent on opioids versus physical therapy, the staffing ratios that we had when you compare our state to other states. In New York, we can't have PT assistants treating injured workers, and that puts us at a staffing disadvantage. So there's a lot of that sort of information that's relevant to them. So coming at it from that perspective is kind of how we went about it. And it wasn't until last spring, I think it was last June, when they officially released a change that they were going to make. And then the state association, everyone I mentioned before, really collaborated over that period of time to put forth a campaign for them to truly modernize the fee schedule. And that's ultimately, what resulted in the change was that campaign that followed. But we felt like we have a new relationship with the board at this point, and that they have much more of an open ear to our input. So that's something regarding advocacy that I think is fundamentally important.
Well, and I think you brought up so many good points along that, and especially going through your journey and your story with how you really did that and how you were able to successfully get into that audience and really kind of present the information in a way that made that effect positive. But, I want to go back a little bit, Brendan, because we talked a little bit in the pre-show about another avenue that you also kind of were involved with that partially contributed to everything as well. And that's when you went to the Workers' Compensation and Insurance Rating Board's annual conference in the past. Now, personally, before you mentioned that, I had not heard of this conference before at all, and I'm sure a lot of listeners out there maybe aren't familiar with it as well. So would you mind just kind of sharing a little bit more about what that conference entailed and kind of sharing what your experience was with at that event and how you used that event to make an impact?
Yeah, absolutely. So, so the timeline is clear. So in June of last year, just about a year from now, literally almost to the day, is when the board put out their proposal. And what was on the agenda for, ourselves was to have a, engagement campaign, public relations, with the board. There was a lot of debate about meeting with the board again and having a discussion. But there's red tape to get in front of the Workers' Comp Board. Typically, as it was described to me, getting in front of the Workers' Comp Board requires the governor's office approval. Like, nobody can just call over there and say, hey, I want to come in and, have a meeting. And, this, Insurance Rating Board annual conference was a relatively new event. I think that this year it's going to be the third annual, but last year it was obviously the second. And the rating board is not the Workers' Comp Board. It is the individuals, the actuarials that run the numbers. And it's kind of a who's who of who's involved with the system. So every stakeholder is there. You've got leaders from the Business Council to leaders of labor, former heads of the Medical Society are there. The Chiropractic Association had representation there. You have all the executives from the Workers' Compensation Board on hand, from the chair to the executive director to their lead counsel. The individuals that are, again, the actuarials who run the numbers on the system. So the rating board basically is the group that looks at the financial health of the system. And they had started, along with this conference, producing reports that they would present at this conference about medical spending, about, drug spending in the system, the fee schedule, really detailed information on what the majority of the system, was spending its money on. So again, in addition to getting really good information, this was an opportunity to be in a room with a couple hundred people that, were directly involved in the process. And it's not as though you could, walk in there and expect to get an answer about how, the fee schedule would change. But I think it gives you the opportunity to go to an event like that, to network a little bit, and potentially get in front of, the Workers' Comp Board again. And again, without having, the governor's office approval of having a formal meeting, you can walk up to the executive director or the chair and just have a brief conversation. And whereas in the past, physical therapy, might have been just, kind of a faceless organization, you kind of get to show and demonstrate to those individuals that are making these decisions that you're committed to the process, that you're not just there, for lack of a better term, for a cash grab and to go in and say, hey, revise the fee schedule and, life will be perfect. You're demonstrating the value of your involvement and your commitment to the injured worker. If there was one piece of advice that I received going into things over the last few years, it was from Jeff Hathaway. And he said, look, you can't go in there and just blather on about physical therapy and what it is. Everything is in the context of the injured worker. And it's the same way with most things that we advocate for, whether that's, keeping copays low or otherwise, or the Medicare cap. It's about the patient. It's about the individual. And there's a lot of people that have a vested interest in making sure that injured workers really are taken care of well. And the workforce is extremely important to every given state, because that's where the majority of tax revenue comes from. So having good, sound policies there and showing that you're committed just not to your own issue, and having, really a depth of understanding for that is something that's fundamental, and something that I tried to prepare myself for, going into that, and not just, kind of be a single issue person with a lone understanding of things.
Are there other conferences that are similar to this, Brendan, that where physical therapists can engage with third-party PT payers?
Yeah, I think that there are a lot of different conferences that exist. I mean, I've always been someone that looks, throughout the state to see what's come up. I've attended, here locally in New York. There was an annual conference. I don't think it goes on anymore the last couple of years, but it was the Health Information Exchange, what's called HICSNY. New York State is one of the states that's really trying to lead regarding putting together, an online, network of, connecting patients' health information through a central database. And I had attended that conference for a couple of different years, and actually who attended that was, some local heads of HMOs. And so again, it's not every day that you can get in front of some of the CEOs there. But that was a conference that stood out to me. In particular, I've looked ahead at, this fall, and there is a New York Health Plan Association. And, anytime that I see something like that, where, we could convey the message of physical therapy and how we've evolved and what we think our role can be in terms of reducing costs, better outcomes, et cetera, that's the kind of meeting that, I'm interested not just in attending, but I've presented the idea of actually going there and giving a presentation. I believe, fundamentally, whether it's the, workers' compensation forum or otherwise, you got to go where it's going to be a little uncomfortable. You got to be prepared to go into a place where you're going to be challenged, where, physical therapy might not have the top of mind awareness. Not everybody is going to have, the best impression, and you're presenting, information to them that is new and different. And we have a good story. We've got a great narrative. And I think looking for these kind of events to spread the message about what we can do should get us out of our comfort zone and put us in a position where we're not just in front of one payer. We're in front of a large group and people that make fundamental decisions, and put that in a context to where we can truly help with societal change and strengthen communities, really in line with, the APTA's vision. And if you kind of paint a larger picture, with regards to that, perhaps, the profession is seen in a different light rather than just its own expense, really on a balance sheet.
Well, I think you make a good point, because I know that physical therapists are sometimes criticized for being relatively insular healthcare providers. And so, this is a really great example of getting outside of the profession and, again, focusing the conversation around the patient. I think that that's one thing that maybe we could do better at with advocacy is, we always talk about, well, us, we need to be paid more, but really, lawmakers and policymakers don't necessarily care about us, they care about their constituents. So trying to get that message to be more focused on, say, the customers of an insurance plan, helping them lower their costs, because in the end, insurance companies are worried about cost. They have shareholders to please, and so making sure that unfortunately profitability is a big part of it. So helping them with that by offering alternative services, I think, is really important.
So, Brendan, of course, you mentioning earlier about, kind of some of these preconceived notions or, stigmas, shall we say, regarding kind of pushing more for reimbursement and, some of the struggles that can entail. One thing that you had kind of mentioned that I've heard myself in the past is that some people have said that, we shouldn't pursue more with changing third-party payers for high reimbursement as something along the lines of, we've tried that in the past and it wasn't really successful. Given what you've gone through and kind of you explaining kind of your methodology and how you were able to actually lead to this change specifically, what are your overall thoughts on this?
Yeah, it's a great question. Look, if, what I hear, on your show and again, in social media forums and otherwise, and from, even, the fellow practice owners, if salaries are going to rise and student debt is going to become less of an issue, then reimbursement has to change. It has to, at the very least, keep up with the cost of inflation. And that's where the value equation comes in. And, you've got to look at cost, you've got to look at quality. And I think that there's, a strong belief within the profession that outcomes and data, if we get enough data, it'll carry the day. And I truly do believe that that's an important ingredient, but I don't believe that it's the data alone that's going to save us. I think that the profession, needs more than that if it's going to look at changing reimbursement and how physical therapy is utilized. And, I'll try and communicate, this fundamental understanding for fellow professionals. I think as PTs, we see ourselves as stakeholders who deserve a seat at the table. And if you look at something as important as opioid task forces that have gone on statewide, countywide, and at the national level, there are many that have taken place that have no PT representation. Other stakeholders, when it comes to insurers, might just see us as a service or an expense and not something that is unique. And it might just all be bundled in with, rehabilitation. So we've got to learn to be able to separate ourselves out from that. And, really in the healthcare landscape and worlds of spending, we simply might not be, in a position or large enough to have a seat at the table. That's traditionally reserved for insurers, physician groups, pharmaceutical companies, et cetera. And we have to understand that, we might be pushed around as a bargaining chip on the table rather than having a seat at the table. And what I would say is that the profession, we have to acknowledge that PT is still a relatively young profession. And, that we've got a lot of work to do, that we've accomplished, truly a lot, but there's a lot that has to change. And, one of the things, as it relates to the profession, understanding, our role, is the fundamental question for physical therapists about the value of the physical therapist diagnosis. And, I'm going to just recount this story, quickly and show how it ties into, a larger issue related to Medicare. But I remember over the last year, I was, in an online Facebook group, I think, and a undergraduate student that hadn't quite gotten into the graduate level was evaluating whether or not they would apply for PT school, and they were out in Buffalo. And this student posed the question to the group of whether or not physical therapists provide a medical diagnosis. And again, my role with the state association, my knowledge of the issue was clear, and that is that if you go to our State Practice Act, that we contribute to the making of a medical diagnosis. And the Workers' Comp Board very clearly on its question and answer, session with regards to whether or not therapists can, seek what are called variances that, extend outside of the medical treatment guidelines that we have in place, that because physical therapists do not provide medical reassessment, the answer to that question is no. We do not provide a medical diagnosis. And, that, obviously when the student asks that question, and I'm just stating this plainly as fact, and it's not as though several therapists jumped up and down and attacked me personally, but the traditional arguments came out, and that is, hey, your physician doesn't know more than I do. Medical diagnosis doesn't mean, as much as my opinion. We're experts in musculoskeletal care, on and on with the value of what we do, which I don't disagree with in any fashion. But what I would say is this, is that to tell ourselves that a PT diagnosis has greater value within the overall healthcare system than what a medical diagnosis or what a practitioner that can provide a medical diagnosis is like wrapping yourself in a warm blanket and keeping yourself comfortable on a cold winter evening, because it's telling yourself a good story that might feel good. But when it comes down to how professionals are reimbursed, when you look at what are called E&M codes, evaluation and management codes, they're typically reserved for physicians, nurse practitioners, PAs, podiatrists, etc., who actually provide medical diagnosis. This is a different tier of reimbursement. To make the leap that we can get the PT diagnosis on the same scale as the medical diagnosis, it might be a stretch if you were looking to convince regulators, legislators, fellow stakeholders. It matters that there's a fundamental difference, and the profession has to understand that yes, it's good to be able to tell ourselves that we are experts, but how the overall system functions is that it places a value on those individuals that are able to provide a medical diagnosis. So if you look at the 2018 report that came out from MedPAC, and that is the advisory group that advises Medicare regarding payment, there was specific reference to the idea that E&M codes, these evaluation and management codes, were undervalued for office visits, hospital, outpatient department visits, etc., and that they were going to look to actually change reimbursement by making a cut to physical therapy as being one of the services that was actually overvalued. So that's where that issue kind of comes full circle, is that if we convince ourselves that PT diagnosis is equal, but a group like MedPAC that is making the rules at the very top level of Medicare doesn't see it that way, then we've got to consider how we're going to advocate for our value. It matters to the discussion that therapists are honest with themselves. It doesn't put us at a lower level of what we know, or doesn't say that we're an expert, but we do have to look at how the system values, the different levels of what, different providers provide to the system.
Yeah, I think that's a really good point. And, those discussions that are had on social media are definitely rich discussions in trying to figure out how we're going to approach some of these problems. What do you think about how APTA has advocated for reimbursement over the years?
Yeah, I think APTA has done a great job in being directly involved, in the process as best as possible. It's just like the state chapters, it's an advocacy group. One of the issues that came up, for ourselves, that, was a part of the internal discussion was, as a state association, how much can you advocate, for, specifics in terms of reimbursement? And there's issues with that you always have to consider, that you can't, appear to be colluding, as a group of therapists to just force reimbursement into a certain position. So I think APTA, has done what it can to get in front of as many people as possible. I do think that the, Choose PT campaign has been a big part of that, to raise public awareness. But I think on a state level, state chapters, have to look to be involved, in those conversations. I think that when I had listened to one of Karen Litzy's podcasts last year, where she had a conversation with Sharon Dunn, our Dr. Dunn, the president of the APTA, that the PT PAC was the 6th largest in Washington. So I think that there's plenty effort and energy going into that. But I think the value of what physical therapists can bring has to be done, in discussions centering around opioids and ways in which we can make a difference. And that, the role that we play in keeping costs down, throughout the system is, has to be looked at as a priority. The discussion with the Workers' Comp Board, again, it didn't center around, when I got to give that, that talk, didn't center around, dollar amount. It talked about how a fundamental physical therapy visit that is of quality, really relies on having the time with the patient to spend one-on-one time. Pain is complex. Getting people to understand that at a policy level. Looking at a group like MedPAC, I've looked at the list of individuals that sit on that commission. I think there's opportunity to get in front of these individuals the same way that I did, with the Workers' Comp Board at the state or at the Compensation Rating Board meeting. I think the more that you personalize it, the more that therapists are on these different committees and so forth, the better off we are. I think we, in terms of that, need a seat at the table. Looking at that group, there's anything from judges to physicians to individuals with their PhD. There's a pharmacist. There are nurses. MedPAC needs a physical therapist on there. I do think that that's one area that I would look to be building relationships with and moving in that direction. The more that the message is out there, the more direct and more personal people know about who and what we are. That's an area that I would look to enhance. But I think APTA has done the best possible job in its role as an advocate for the overall profession and not just one particular piece.
Right. And Brendan, going back to what you had kind of mentioned in your previous discussion there about, really showing the value of what we can bring, part of that being cost. And I want to switch and kind of touch base on an article and kind of a situation that I had heard about last year regarding what the city of Denver had done with hiring full-time physical therapists, and this ultimately leading to significant drastic financial savings. As the article was published, I think it was March 2018, and the Evidence in Motion podcast covered this as they interviewed, I think his name was Dan Jonte, to talk about this a little bit further. But I want to quote the article because I thought it was really profound when it said that, quote, "The director of the city's health and wellness program said that among the fire, sheriff, and police departments, having in-house PTs has reduced workers' compensation claims by $8 million over the past 2 years." Now, clearly that's astonishing. And, I want to dive a little bit more into this. As what do you see as the strengths and barriers to making this phenomenon maybe more of a common theme across the country?
Yeah, it's so interesting when I saw, or just, had seen your question in advance of the show and just you reading it now. It's so funny because I saw that article the day that it came out, and it just so happened that at the time, on the day that came out, it was a snow day, for my office. We had to cancel and send all patients home and otherwise. And I said, I've got a few minutes, and I see Daniel's name on here. And I picked up the phone and I called out to Denver, and it just so happened that he gave me an hour of his time, to discuss exactly the program, how it came about, and, their initial success with it. And so I really got kind of a, upfront in the beginning, personal view on that. And, really what he had described to me, and I think some of that is reflected in the podcast that you referenced with EIM, is that relationships are built there, that, to make that a successful program, to achieve, that level of savings. Daniel is, an employee of the city of Denver. He is embedded with and has built relationships with those individuals. I think that is something that's really fundamentally different than a city saying, if Albany, New York said, "Oh, look at the city of Denver. They, put on physical therapists and they saved a bunch of money." And they went and they just contracted with a physical therapy group. And that physical therapy group then just provided service. You might not get the same result. The impression that I got in my discussion with Daniel and listening to that podcast is that he built relationships. It was a start to finish type of program where when new recruits come on, that they do screening in advance, that he, works with them in a very one-to-one basis and builds that rapport and relationship about what they go through. So he knows the intricacies of what goes into it. I think it's a fantastic model. I think it takes, a commitment, and it probably takes the right people, at the level of the municipality to see where bringing on a therapist can save money. And I think this adds to the discussion about our fundamental value. Workers' compensation is an area that physical therapists, really should own, proudly in terms of making a societal difference. I think it makes an impression on all the right stakeholders. And if you had, this as kind of the national standard, the number of connections and goodwill that physical therapy would bring about, it would be overwhelming, the information, that could be brought into the public square to show what physical therapists do, rather than, another randomized control trial comparing, a mobilization to a manipulation. Something like what he was able to accomplish there, the people that were involved that gave him support, it is a game changer. It is the sort of thing that is advocacy beyond a level that I can possibly do. And I think, again, builds those relationships and goodwill to an extent with the people that you would want it to.
Yeah, I think that you make a really great point. And I think that it's important for us to keep this stuff in mind because, again, this is not an easy process. And the more that we can get the general public to buy in and to kind of see what we can offer, I think the more successful our advocacy efforts can be, because public pressure can really mean a lot. Do you think that DPT education adequately addresses advocacy? And do you think that do you have any other recommendations for programs if you, based on your opinion?
Yeah, I think so. What I had referred to earlier with the idea of the profession being a young profession, it's come a long way. It's easy, I think, for the profession to a certain extent. There was maybe some degree of belief. I can't say who, but the idea that we had achieved the doctoral level, and we've got a good amount of evidence going into what I do, that would be enough, and that if we have the doctorate title and we have the data, that a lot of good things should happen for the profession. And the way that I like to describe it is that the DPT, it's a title. It's a title, for our profession that is the appropriate designation. But being a PT professional, it's about carrying the mantle of the profession, and the profession, carrying the weight of that, is fundamentally different than just having those letters after your name. It means that you're engaged in not just clinical practice, but addressing the needs of society and having a good, solid inward reflection on the profession and how to be a steward, of the profession and move it forward beyond, just what you're doing today. And that change is generational, and giving, I think, students an understanding for generational change rather than, hey, we're just going to advocate for this issue and then everything's going to happen. The profession has come a long, long way over a period of time. And I think just taking that perspective into things, I think it was last September, I was at the WebPT Ascend conference in Arizona, and Dr. Dunn, I think, gave the closing address, and she really meticulously detailed the evolution of physical therapy as a profession and all the trials and tribulations that we faced over the course of decades to get where we are, and that, the weight and the responsibility of moving the profession forward, is still there, that we have a long, long way to go in terms of that. I think DPT and PTA, educational programs, advocacy needs to be discussed as it relates to reimbursement rates, salaries, debt and earning ratio, because it directly impacts when you go out practicing at the top level of your training for your license and your professional satisfaction. So much talk these days about, burnout and therapists not feeling like the profession is meeting, the expectations that they had going through school. Having that honest conversation in the beginning about where the profession is, it's a good opportunity for a history lesson, but it also lays the foundation for how to get involved and what directly you can do about it, rather than expecting that it's just going to happen over the course of time and just by the course of change taking place.
Yeah, Brendan, I think that's a really, really solid point on there. And, I want to dive into one thing we haven't talked about yet formally, and this is kind of something you had told me about in the past, is that you've been working on an advocacy training forum for the fall conference with NYPTA. Now, would you mind sharing a little bit more about this forum and kind of what are some of the key take-home points that you'd want to drive home to all listeners?
Yeah, absolutely. So our state fall conference is going on in October, and the dates here I think are going to run from Thursday the 17th, where there's a pre-event training session, and the actual event is then a couple of days after. I want to say the 18th and 19th. But what has been discussed as a part of the public policy committee, that I serve on, Jake McPherson is the chair of that committee, and honestly, it's an idea that I thought of, but it's really, he deserves full credit for putting this into place. And as soon as he mentioned it, I jumped out of my seat and I said, yes, this is exactly the sort of thing that we need to do. So as I referred earlier, advocacy means a lot of different things to different people. But if somebody's willing to, really get into advocacy and understand public policy matters, there's a lot of nuts and bolts that go into it. And so what we're looking to do and how things are structured now is that, it's going to be a half-day event where topics from workers' comp reform to direct access and PTA licensure legislation, all of that is going to be what the topics are. And over the course of these 4 hours, individuals, I think we have it around 35 attendees is what we're planning on, are going to learn how to successfully advocate for the profession and in a manner that's consistent with the most recent evidence. Participants will learn, anything from how to identify who their state legislator is, how to schedule appointments, how they can be involved at that level with the state association. We talked a lot about doing, mock sessions where, how did these discussions typically go? If somebody's receptive or not receptive, what sort of information, really how to have a very succinct message. The committee that I chair with the state association is the Opioid Alternative Special Committee. And, we've produced some documents that are, shared and distributed on Lobby Day with regards to an individual legislator's counties that they are in, represent here in the state of New York as it relates to opioids. And so really giving specific information that's relevant to them is the sort of thing that, would be covered as a part of this. So individuals feel like they've got a good command, not just over typical physical therapy talking points, but again, information that's relevant to that legislator or that individual that you're meeting with, so that individual would understand what are the legislative priorities that go into it. I think it's the sort of thing that we're kind of trialing this year and can see whether or not this sort of thing grows. But I think it's a great opportunity for students to go into to say, wow, this sounds just daunting, New York State legislature or otherwise. What will this look like? And really learning the nuts and bolts of that. It's something that my understanding had gone on years and years ago, and we're really looking to reestablish at this point because it's so important.
I think, Brendan, that you've made many good points in this podcast and also have helped our listeners understand the intricacies of dealing with insurance companies, understanding how they work, and just understanding how the advocacy process works in general. So thank you so much for joining us on our podcast. And at the end of our podcast, we ask everybody a standardized question, and feel free to answer it based off of the information you've already given us or on something that is maybe even off topic. But if you could change one aspect of healthcare education, physical therapy or other profession, which aspect would you change and how would you change it?
Yeah, so this is such a great question. I've listened to many episodes on your podcast, and some people go macro, and I'm going to say micro within the PT education world. And obviously, there's going to be inherent bias in my answer based on kind of my professional involvement with the state association, otherwise on the workers' compensation issue. But I think with all the focus on the opioid crisis and all the numbers and information that's put out there, and workers' compensation and the impact that went on for the treating of injured workers is really not spoken about enough. And therapists that get training in this area, in treating workers' comp patients, I would say primarily goes on out in the clinic. And the more that state agencies, whether it's workers' comp board or legislatures, are looking at medical treatment guidelines, therapists need to have a really good understanding for what those are. So again, here in New York, we have medical treatment guidelines, and it's really the embodiment of evidence-based practice and codified into day-to-day practice within the regulations and what you're able to do or not to do. Knowing how to navigate that, and again, this speaks to your question regarding learning all these different rules and so forth within, practicing as a therapist, it's really important. And I think therapists that are completing school and, looking to treat this population, maybe there's some inherent bias, I think, that goes on. The connotation, I think, towards injured workers centers around malingering and secondary gain and some of the challenges that you face there. But when you really think about the pain experience, the biopsychosocial model, it's very appropriate to individuals that have been injured at work. There's been, a loss of status. There's stress. There's, changes that occur to someone's family. This is a true, life-altering event for this patient where it's going to change perhaps their earning potential. There are stresses around that, and going through the system and dealing with the legalities, just that can impact the entire, patient's experience, their ultimate outcome. And there's so much difficulty within that I think it's underexplored. And therapists need to have a good understanding for the treatment guidelines in terms of what should be done, but also their overall system. I've always thought of therapy and working with patients, and in particular the injured worker, as therapists become case managers. Everyone tends to see, an injured worker for a short period of time, but we're spending a lot of time with patients, and having a really good grasp for all aspects of that, how they go through the system, all the different forms that are required. You can alleviate a lot of that stress by demonstrating not just good clinical skills, but an understanding for the system. And I think as it ties into demonstrating our value with stakeholders, having therapists trained in this would be one area that I would add to education. And I don't think it has to be lengthy or otherwise, but I think as it really ties in very nicely, again, with advocacy and everything that we want to be able to accomplish.
Well, I really like that, because it's been interesting. The more we've kind of done this podcast and the more diverse answers we've gotten, because as we started out, we kind of got definitely some more answers were more common and more prevalent, but it seems like now we're getting so many more unique answers and responses that we're not getting as much overlap. So I really appreciate that. And I really appreciate, your thoughts on that, because I think that's a really good avenue to add. But Brendan, I recognize that, of course, we've kind of scratched the surface of this topic, and I get that it's definitely complex, as you had kind of alluded to earlier. But where can people learn more about this topic, or should they want, or reach out to you, should they have a question on anything we talked about today?
Yeah, absolutely. I mean, there's a couple of different places. I'm not on Twitter a ton, but if anybody wanted to follow or reach out to me on there, my handle is SulPT, CSCS, or they could email me. And that is, my personal email, and, personal and work email is info@empirehwc.com. And anybody could reach out, have a question, and I'd be more than happy to share any of the information that, I referenced here.
Well, perfect, Brendan. And thanks so much again for all that you've done throughout, your career thus far to make this change, and look forward to seeing what you and your group continue to do for the profession, and along with inspiring others to make that positive impact. And of course, for coming on the show to talk today.
Great. Thank you so much for having me.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.